to everyone. Honored to be here today. Thank you, Dr. Sparias, for inviting me here today. So my talk within the next few minutes is going to be more echo assessment of the systolic function of the right ventricle, as well as a measurement of the pulmonary artery pressure. With echocardiography, we can do, as you can see here, a lot of measurements with the 2D, M mode, as well as Doppler. Many of those things that we see here, we're going to discuss within the next few minutes. But what I want to start with is that in regarding to the 2D assessment of the RV size, but also the systolic function, we're using a lot of images, but in order to see the RV and monitor and measure the systolic function, we usually go to the apical view, where we see the dedicated RV view, where we want to see the RV on its whole. We don't want to go with the image at your right side, where we miss the apex as well as most of the medial part of the ventricle, but we want to see a dedicated RV view. Here you see that we actually miss the RV outflow tract, but at least we have the rest of the ventricle. Just a brief of the geometry of the RV. As you all know, as you all remember, the RV has actually a crescentic size. At the top of our cursor, when we are placing the echocardiographic probe on our patient, we see actually most of the apex of the LV, and we need to see the RV like you see it on the left side. When an RV is dilated, because, for example, a patient has pulmonary hypertension, the apex of the RV gets this crescentic shape of the RV gets destroyed and becomes more rounded. In regards to the assessment of the size, I'm not going to say a lot of things because this is not a part of my presentation today, but just a reminder that we do a few of measurements. We measure the RV, again, from the apical window, the basal, the mid, as well as the length of the RV in order to decide if it is dilated or no. In regards to the RV function now, we have older but also more recent guidelines that give us a lot of information about how we can measure, as well as a lot of literature. Just a reminder that the right ventricle is a little bit different from the left ventricle. The right ventricle actually has a lot of longitudinal movement. However, the left ventricle has all three: longitudinal, radial, and circumferential. This is exactly what we want to evaluate the RV in regards to the systolic function, the TAPSE. We actually evaluate the longitudinal movement of the right ventricle. TAPSE is actually tricuspid annular plane systolic excursion. It actually we actually evaluate the distance that the tricuspid annulus moves up and down during systole. It is important to align our cursor actually parallel to the movement of this longitudinal movement of the tricuspid annulus. What we actually do with the echocardiography is that we zoom at the tricuspid annulus and we place our cursor at exactly where is the lateral part of the tricuspid annulus, and we measure the distance through the M mode at the bottom of the diastole to the systole, the longest distance. And when this distance is more than 1.7 centimeter or 17 millimeter, then we say that this patient has normal RV function. However, we all know that TAPSE gives us information only about the basal RV. There are people who have abnormal RV systolic function even with normal TAPSE when the mid or the apex of the RV is not moving well. There are data that are actually linking the TAPSE with outcomes of the patient, and that's a very important measurement that we have to have in all our measurements. The next measurement that we use in echocardiography in order to assess the right ventricle is the tissue Doppler. Via the tissue Doppler, we actually again evaluate the longitudinal movement of the RV, but now not the distance, but the velocity with which the tricuspid annulus moves up and down during systole. Here, what what we actually do is that we place the tissue Doppler, we use our PW, and we place it exactly at the annulus, not at the myocardium of the RV. And there we try not to measure the first wave, which is actually the wave of the isovolumic contraction, but actually the actual contraction, the S wave. And when the S wave is more than 10, then we say that this patient has probably normal right ventricular systolic function. I'm saying probably because, again, we evaluate the basal part of the RV and not the entire RV. Again, here there are data that link the RV systolic wave with the outcomes of the patient. And again, our cursor needs to be parallel with the longitudinal movement. Going forward, another measurement that we do when we want to assess the function of the RV is the actual RV functional area change. Here we measure the RV area during end diastole as well as end systole. So the area in diastole minus the area in systole divided by the area in diastole multiplied by 100 gives us the functional area where when it is more than 35%, then we say that this patient has a normal RV function. Here we have a lot more information about the RV than with the TAPS and the RVS, and the only part of the RV that we are missing is the right ventricular outflow tract, which actually we only assess with the parasternal and short axis view, and only when we see it with eyeball. Actually, the FAC measurement is the one that has been very well correlated with measurements that we do with MRI. So when we have a patient that we really need to assess the RV, this is a measurement that we want to do. A study from a few years ago shows that in people who have a heart attack, an acute MI, FAC is one of those echocardiography measurements that actually predict their outcome. RV strain is a measurement that we do. It's actually an easy measurement that we do in our everyday life. We used to do it for the LV, but the last many years we do it actually for the RV. It's I would say a measurement that it's easier to do for the RV than for the LV. We actually do the same thing. We use a narrow sector, but we make sure that we have the whole RV in our plane so as not to miss a few segments. We have, however, our sector as narrow as we can so as to have a high frame rate. We perform the strain in the RV like we're doing it in the LV. However, we disregard the segments that are in the septum, and we only account the 3 segments that are in the lateral part of the RV. Actually, it's 3 numbers. We divide by 3, and we have our number for the RV strain. And when it is more than minus 25%, then we say that the strain of the patient is normal. For the RV strain, there are a few data a few years ago, but also more recent studies that, again, link the RV strain with outcomes of the patient. It is very important that now we are independent of the angle, and of course, it is vendor dependent. One more thing that we do, if we have a machine that does 3D, then we have the ability to do a 3D calculation of the right ventricular ejection fraction. In that measurement, we actually not using area anymore, but we're using volumes. So now we have the right ventricular end diastolic volume minus the systolic volume divided by the end diastolic volume, and we have our 3D assessment of the RV. Again, dependent on the vendor that we have, we take actually a full volume of our right ventricle. We try to have all the right ventricle in our sector, and we use multi-slice in order to make sure that we see our RV. Usually we make our patient do a multi-beat. We have our patient hold the breath, and then we are actually measuring via the curriculum that has each machine, and we measure the EF. And we have a graph that looks like that, like the green graph here. The prognostic value of the right ventricular ejection fraction via 3D was shown to have very, very good correlation, again, with the adverse outcomes of our patient. In a very recent meta-analysis in JACE, the 3D evaluation of the right ventricular systolic function was actually the best measurement that we can do in order to evaluate the 3D. The systolic function of the right ventricle. I'm just mentioning the myocardial performance index. It's actually a measurement that we don't actually do in our everyday practice. It's actually the time that the right ventricle spends in having the tricuspid valve open in regards to the ejection time, which is the time where the blood comes out from the pulmonary valve to the pulmonary artery. What we need, actually, we need less time of the tricuspid valve to be open. The lower this number is, the better the systolic function is. Here, for example, I have an example. I have a patient who has a little bit of tricuspid regurgitation, so we can have a good envelope of the TR, where here we can measure the time from the start of our envelope to the end, which is the opening and the close of the tricuspid valve, and then we subtract it from the time that in the right side the pulmonary valve is open. However, again, in our clinical practice, we don't use that number. Literature says that when this number is less than 0.32, then we say that we have normal right ventricular systolic function. When this number is more than 0.43, like in this case here, it's actually decreased RV function. In the past, people thought that this was load independent, but actually this is again a measurement that is load dependent. So when we have a patient and we want to evaluate his right ventricle, the next question that we have in mind, because when we are doing an echocardiography, we're just don't doing an echocardiogram to do it, but we actually need to say a story about the patient, to have a story that we want to say. The next question that we have is actually, does this patient have pulmonary hypertension or no? When we want to think about the pressures in the pulmonary artery, I'm starting from the end, so I'm starting from measuring the pressure in the right atrium. I'm pretty sure that everyone knows that seeing the inferior vena cava and measuring the diameter, as well as the inspiratory collapse, then we can approximate how much is the pressure inside the right atrium. So when an IVC is less than 2.1 centimeter and the inspiratory collapse is more than 50%, then we say that this pressure is 3. When the IVC is more than 2.1 centimeter and the inspiratory collapse is less than 50%, then we say it's 15. But this is, and in between we have the 8. However, this is as per guidelines, and as we all know, this measurement can, of course, underestimate and probably underestimate a lot the pressure in the right atrium in people who have pulmonary hypertension and very high pressure in the right atrium. Some other echocardiography labs, for example, that one in Mayo Clinic, they use not 15, but they use 20 millimeters of mercury as the highest number that they can give in order to decrease the errors and be a little bit more close to what the cardiac catheterization would say. However, again, you can again underestimate it. So when you have the measurement of the right atrial pressure via the IVC, then you go ahead and you want to do a small cardiac catheterization via echocardiography. How you do that? You have the TR velocity envelope, and you can calculate all the right blood cells that regurgitate through the tricuspid valve. And how you measure all those red blood cells, you actually take the mean gradient, you take the VTI, the velocity time interval, and when you have, and then you add the pressure in the right atrium, and there you are, you have the mean pressure in the pulmonary artery. Of course, there is also another type that they use the acceleration time. However, the most, in the literature, the best way to evaluate the mean pressure in the pulmonary artery is actually the mean gradient through the tricuspid valve. Going forward now, in order to see a little bit more about the TR velocity, the TR envelope, it's very important not to measure the fuzz. Also, when we cannot see very well the envelope, we can give to our patient normal saline in order to make that envelope be more obvious and make our measurement. In regards now to the systolic measurement of the pulmonary artery, we can use, of course, the TR velocity at the envelope of the TR and add it to the right eye pressure. And here we have the systolic pressure in the pulmonary artery. The same with the diastolic pressure. We have our envelope at the regurgitation of the pulmonary valve, and then via the Bernoulli equation and the 4V square plus the RA pressure, we have the diastolic pressure at the pulmonary artery. Again, via echocardiography, this is an assumption. We make the best we can, and as Dr. Kurkovelli said before, it's very, very important in people who have severe TRs, pulmonary hypertension, dilated RV, is a question mark about what we do with those patients. We always want to do right heart catheterization. It's a very tricky thing to measure the pulmonary pressure in patients with severe TR, and we don't need to use numbers anymore. And this is because we know that when the RV fails, then the pulmonary pressure is going to fail. So in a failing right ventricle, we cannot use the pulmonary pressure via echo to say what is the pressure in that patient. There is the RV-APA uncoupling that occurs, for example, in pulmonary arterial hypertension, when there is hypertrophy of the smooth muscle cells in the pulmonary arterioles. So there is a lot of remodeling, and as a result, the afterload in the lungs increase, and there is a problem for the RV to extract the blood to go into the lungs. So important things to remember and account them when we are having a patient in front of us. Based on the recent guidelines, we cannot use TR velocity anymore. We cannot use a number that PASP gives us. We need to use a lot of things that the echo gives us in order to evaluate the RV systolic function and the PASP. Thank you so much for your time.
Thank you, excellent talk. I would like to point out that the RV coupling maybe is the most accurate parameter to evaluate the patient, the right ventricle, compared to the PASP. I would like to ask you, do you think that dobutamine stress echo has a role in evaluation of RV function? What do you think?
It has in regards to the increase of the pulmonary pressure. When we're doing a stress echo and we see that the pulmonary pressures of the patient increase, then we know that maybe there is a bigger problem with the RV. However, in our everyday practice, it's not that we are using a dobutamine stress echo in order to evaluate the RV. I would say more of the evaluation is probably the transthoracic echo and the MRI. But
maybe we evaluate the RV reserve. It's an addition.
Of course.
Data.
Always stress echo is useful.
Dr. Samarkati, please, your comments?
Yeah, excellent talk. Thank you so much for the enlightenment. Though I am not an echocardiographer, but it was a very enjoyment. And being an interventionist working in the tricuspid, we became hand in hand with the our imaging department. So usually whenever we're planning a case, I agree, we usually spend majority of the time on transthoracic for the screening. And afterward, we go with the TEE. And if we have any suspicion of infiltrative myocardial disorders, we go for an MRI. And usually, right heart catheterization goes hand in hand with transthoracic. And then you decide where to go from there.
Thank you.
Any question?
Thank you very much for all the information that you gave us. Are you using, or how often are you using right ventricular, right atrium uncoupling in order to avoid afterload mismatch in patients with right ventricular dysfunction after closure of the TR?
You can use it. I mean, it's actually a measurement that is pretty easy to do. It's TAPSE divided by PASP, so it's actually a measurement that we can do after closure in order to, and it's actually before closing the TR. I think it's very important to evaluate the patient with everything that we said before, including the MRI, the cardiac catheterization, the echo, and the TE, in order to make sure that it's gonna be safe for the patient to close that TR. We want to have an RV that has not failed. So the more important thing for me is to have an RV that is still functional before closing the TR. And your question is that after you place a tri-clip in the TR and you have the result, is after, if we calculate the RVPA coupling? No?
No, it's how we are using it before. Do you have any number? I think then 0.31 is less than...
yes, I think so. Yes. I think it is...
So are you using it in, not everyday practice, let's
not
say,
of
course, when you have right ventricular dysfunction...
When I have RV dysfunction, yes, I use it,
for
but...
example, this patient, it's possible to have right ventricular afterload mismatch after closure of the DR. So
sure.
Just to have an idea that, you know, he's at high risk of having,
so
you know exactly the profile of the patient.
So, for example, in a recent patient that I had with severe TR, I used it in order to see if this patient would have after. However, I do that only if I have a patient that has borderline RV failure or mild RV failure, and I want to predict how this patient is going to do after, and severe TR, of course.
Vivian, congratulations. I really enjoyed your talk. It was so concise and very clear.
Thank you.
I just wanted to make a comment that in patients with pulmonary hypertension, the RV to LV ratio has also been studied.
Of course.
And we use it a lot in congenital patients and terms of low patients, dilated ventricles, etc. So I found this helpful, having to extract from the pulmonary hypertension patients into our congenital patients this RV-LV ratio. Mm-hmm. So you see the RV with a good ejection fraction, but it is dilated, it starts failing. Mm-hmm. And in the pulmonary hypertension group, it's been published at more than 60%, so it should be 0.6. Above that, you see that the RV starts to fail, and when the RV-LV ratio is above 0.9, then the RV is really very dilated, and we see that after our treatment, whether it's pulmonary hypertension treatment or anatomical treatment, the RV-LV ratio comes down. So although we don't do in the adult population commonly with acquired, or yes, sometimes we do, I think this is something very important to add in our everyday practice, because it's very easy to extract from this ratio about how our patient is doing. But thank you again, excellent talk.
Thank you.
Dr. Hirsch.
Congratulations, Vivian, a great talk.
Thank you.
I just want to point out a limitation of the RVPA coupling in the sense that it's an echocardiographic index, and we understand that in severe TR, we can't really measure systolic pulmonary pressure.
Correct.
And we use it for this index. Now, some people have tried to use invasive measurements of systolic pulmonary pressure to create an invasive type of RVPA coupling marker, which seems to work even a little bit better. So just to point out that limitation. For this.
It is a big limitation. I said before that with the severe TR, we cannot measure actually with echocardiography the RV, the PA systolic function and the RV systolic function. And it's one of the limitations. That's why in those patients with severe TR, when we're planning to do, when you are planning to do your interventions, you always do a right heart catheterization, as far as I know.
Correct. Congratulations.
But I think this parameter evaluates both RV function and TR. And this is the most strong parameter value for this parameter. I think a bad RV with low TR has worse RV coupling. So it's very, I think that there are data concerning the prognostic value of this parameter in patients with severe aortic valve stenosis, with MR, severe MR regurgitation. I think it's a very strong parameter. Evaluates both RV function and TR. And velocity of TR, and I think it gives us a very valuable parameter. Okay, so we can continue with Dr. Drakopoulou, anatomy.